The session is live stream, so you can start the session.
Shall we start? Sir, Saraswati?
Yes, yes.
Right. A very good morning to all of you. I'm Dr. Jyotsna, convener of the Young Neurology Forum, and along with Dr. Saraswati Nashi, who is the chair, I welcome you all to yet another YNF session. And this session is as promising as the earlier ones. We have senior people, we have young, budding neurologists, and junior but trained, very talented neurologists on this forum. And the theme for this week or this session is movement disorders. To moderate the session, we have the senior moderator, Dr. Guru Prasad Hosulkar, sir. He is the director and lead consultant of the and head of the Parkinson's disease and movement disorder program at KIMS Hospital, Bengaluru. He is also the secretary of KNA Neurosciences, Karnataka Neurosciences Academy. Sir, we are honored to have you on this program and share your thoughts on this adaptive DBS. I request you to take over the session and introduce the presenter. Welcome, sir.
Thank you, Dr. Jyotsna. And being amongst the young neurologists, you feel young, and how better to be on a Sunday with young neurologists and budding neurologists across the country. So, thanks to IAN Momentous of Section and Young Neurologists Forum to having this webinar. Before I introduce the speaker, Dr. Sneha, I would like to give a little bit introductory remark on what's happening in the adaptive DBS field across the world and India. I will not take much time because Sneha has a good presentation to present for you. I think we were in the generation where we saw the DBS coming into India because I trained in Jaslok when the DBS came into India, and then we have seen the developments over the last 20-25 years. And we have seen through a lot of new developments, new technologies. So new technologies definitely are welcome, but it also brings with it a lot of challenges and new learnings. Always a steep learning curve. And for last few years, we've been hearing about biomarker. That means local field potentials. So Medtronics brought this sensing technology, and it has gone almost like 10 years before it came into commercial use. And last few years, a lot of centers in India and abroad have been using this technology, sensing technology, where we look at the local filtered potentials, both STN and GPI, to look at the thing, and then utilize that for targeting the nucleus, whether it is STN nucleus. So it has helped in a way, but otherwise we used to use the platform, the planning platform for that, and it's been a robust biomarker, I must say. We've been using this for many years now, last 2-3 years, and it has been a good biomarker, I must say. And then it is quite, reproductive, and it is seen across patient clinical phenotypes. Having said that, in last few years, there are trials where they have gone through where we can use a closed loop. So that's what it is. Adaptive DBS is all about closed loop, where there is a real-time personalized adjustment of the programming parameters. Of course, the thresholds are all have to be set by the clinician, but that is a paradigm shift in terms of programming. We have gone through directional lead, we have gone through horizontal steering, vertical steering, from non-rechargeable to rechargeable, non-rechargeable to rechargeable batteries and all. But this is a thing made for neurologists who are the main programmers, post-op DBS. Neurologists are the one who look after the patient. So this gives a added edge. We have recently image-guided programming, but this adds new paradigm shift in terms of programming. So that way, adaptive DBS, it's a new baby on the horizon. We need to adapt to that, adapt DBS, and also see how it, how you can bring it in practice. We have a small experience, or recent experience, where it was introduced in March. In fact, it is only available in few countries in the world. It is available in US, Japan, and we are probably the first few countries where it has been introduced. I mean, our government and authorities have been very fast to accept it and give the clearance for usage. So we had some 1 or 2 months of experience using Adapt DBS, and Dr. Sneha will share our experience thing. So Dr. Sneha Kamath is attending consultant at neurologist at KIMS Hospital, Madhava, my colleague, and she is a Parkinson's and movement disorder specialist. She did her DM from NIMHANS, and then she did her movement disorder PDF and Dr. Pramod Pal from NIMHANS. She also has other interests in terms of genetics. So good to have Sneha for having this talk and share your experience. Welcome, Dr. Sneha.
Good morning, sir. Thank you for that kind introduction. And also, thank you to the Young Neurology Forum, including Jyotsna ma'am, Saraswati ma'am, and also Srinivas sir is here. I can see already that there are 74 participants, so people are quite active even on a Sunday. Without any further ado, I'll just quickly share my presentation. And actually, sir has almost finished the majority of my presentation, so to say. But nonetheless, as we go along, I'll just start sharing 1 minute. Is this visible?
No, not it, not it. Yeah, no, yeah.
So I don't have any declaration, no conflicts of interest to declare. But yes, I understand that we are having a very heterogeneous audience. Of the 70 members, there may be people who are quite early into neurology. There may be those who have finished their neurology, and there may be those who are already practicing movement disorder and are very interested in learning about deep brain stimulation. So in case there are any questions, please place them in the Q&A box. Dr. Guruprasad sir and myself will be very happy to discuss regarding these questions as we go along. Once again, because there's a heterogeneous group, I'll be having both basics as well as the advanced topics to be discussing about today. So as we all know, deep brain stimulation is a targeted circuit-based neuromodulation of structure. Why do I say that it is circuit-based neuromodulation? Is that basically when we see the basal ganglia, the circuit is we are all aware of, but whenever there is diseased circuitry, there may be increased stimulation from certain areas, there may be decreased stimulation from certain areas. And when we use some form of lesioning, which is like an anatomical lesioning, we cut off those circuits entirely. But on the other hand, when we do something like deep brain stimulation, we change the frequency of the signals coming out of these deep nuclei, either by desynchronizing them, by providing high frequency stimulus, or by inhibiting neuronal firing from areas which are known to have abnormal stimulatory firing. So when we think about deep brain stimulation, we have to understand that we are providing an electrical impulse, and that electrical impulse is having certain properties. The most important property obviously is decided by where the lead is placed. But apart from that, there are three other modifiable parameters, which is basically the amplitude of current, which in the presence of the lead location will decide the volume of tissue activated, or VTA, the frequency of the stimulation, which can either be high frequency or low frequency stimulation, and the pulse width of each burst of the electrical activity. Now, in addition to this, all of the current we know is not just given by the leads. They originate from somewhere, which is the implantable pulse generator, which is placed in a small pocket below either the right clavicle or the left clavicle. It's a subcutaneous pocket. And from there to the lead in the brain, we always have a connector or an extendable wire. Now, DBS has been approved for advanced PD as a standard of modality of care from 2001. Both the GPI as well as the STN has been approved. The common indications for DBS in Parkinson's disease patient is levodopa responsiveness, which is about 30 to 50% improvement in the UPDRS scores once they take levodopa. But in addition, the patient should also be having disabling motor fluctuations when they take this levodopa, which is why recently there was a Delphi consensus and release of the 5-to-1 rule, very similar to patients who are undergoing the epilepsy surgery. It basically means that if a patient is advanced enough that he's taking 5 doses of levodopa, mind you, it is 5 times of the medication and not 5 tablets, or is having 2 hours off, which is disabling, and is having 1 hour of dyskinesia, which is disabling, then the patient can be considered as a suitable candidate for the advanced care, especially DBS. Now, this rule is not isolated to DBS, but it's a very good rule when you're thinking as an early career neurologist that this can be used as a standard wherein we can start thinking about DBS for the patient. In addition to this, sometimes there are some symptoms that do not respond to levodopa. But if a tremor specifically is not responding to levodopa, while the rigidity and bradykinesia is responding well enough in the 30 to 50% range, also the patient becomes a candidate or a suitable candidate for Parkinson's disease. In the absence of appropriate red flag signs, which is like an early onset of autonomic dysfunction, early onset of eye signs, early onset of imbalance, the patient is a well-diagnosed case of Parkinson's disease, and the patient does not have active ongoing psychosis or the patient is not having severe cognitive decline, then the patient can be considered a suitable candidate for Parkinson's disease. Now, currently, we are in the era where we are shifting between the older to the newer technology. The older technology, as described on the left-hand side, suggests that we are having what is known as continuous stimulation DBS or CDBS. Now, while it is definitely a progression from what we have originally seen in the early 1900s, wherein it has become fully internalized, it is a lesser cumbersome device that we are carrying around, it is inherently disadvantageous. Patients will often have fluctuation despite being on continuous stimulation because the medication effect continues to wear off in the background. The disease continues to progress in the background. There is also stimulation induced adverse motor outcomes when the patient is in the on state, particularly in terms of gait and speech. Also, there is the burden of outpatient visits every time the patient is having either suboptimal stimulation or the patient is having stimulation induced adverse motor outcomes. Finally, because the patient is on constant current, the patient will also have early wearing off of the battery life, even if they're having rechargeable devices. Which is why, like Sir said, in the last decade, there has been a lot of research wherein we are trying to understand about what will happen if the device also starts providing active feedback to the current or the biomarker that we are getting. So in this, as you can see, the cartoon on the right hand side, we can have multiple biomarkers. There can be electrophysiological biomarkers arising either from the cortex, like an ECOG, or there can be an electrophysiological biomarker coming from the basal ganglia and nuclei, which is in the form of local field potentials. Or there can be electrophysiological biomarkers, which are also mechanistic biomarkers coming from wearable devices. Say, for example, someone is having a tremor, they can hold a device that can identify the frequency and amplitude of the tremor, thus identifying when the patient is off. Or if the patient is having freezing of gait, something over the knee or ankle can identify itself as an appropriate marker of the patient being in the off state. Now, whenever we get such a biomarker to which we can have a good recording, these can form as input signals and access itself to a device which can process those signals and then decide on a selective, decide on an adaptive strategy, adjust the parameters which can further change the off to the on state for the patient and then provide stimulation. And once the stimulation is provided back to the basal ganglia, the patient immediately sees an improvement in the symptoms. Now, this is the theory of it, so said. And in addition, what we have to also remember that this particular device is also supposed to sense whether the patient is sleeping, not sleeping, and thereby it is able to step down its stimulation to a point wherein the patient is not experiencing off symptoms in sleep, but is still not using high doses of the stimulation, thereby preserving the battery life. Now, what I was talking about in terms of the local field potential is something that we have learned by repeated testing and sensing in the OT itself. So these local field potentials were initially identified when surgeons were trying to do microelectrode recording and macro stimulation in the OT in the basal ganglia, particularly the subthalamic nucleus. They identified that if the patient is in the off state and if the patient is having some form of off state symptoms like bradykinesia or rigidity, the patient would have a low beta frequency ranging from 13 to 20 hertz. This could go as high as 30 hertz also in the high beta range, but the correlation with the severity of the bradykinesia and rigidity was greater if a peak rose up in the 13 to 20 hertz range. Similarly, if the patient was having on-state symptoms and particularly the patient developed dyskinesia, then the patient would have a peak that is appearing later on, which is like in the gamma range, in the 30 or the 90 hertz. I would encourage all members of the audience to read this paper by Newman et al. It's a brilliant paper in the MDCP in 2023 that is describing about the newer paradigms of adaptive DBS in very simplistic words. So as you can see here, this is the graph that we can see. Not all peaks are visible at the same time. This is just a graphical representation. There will be another graph later on, which I will show you about a real-time patient experience. But basically, if you see a peak in this range in that graph, then it suggests that the patient is in the off state and is having bradykinesia and rigidity. Or if you see a peak in this stage, you may see that the patient is in the on state. That is the absence of this with the presence of this will say that it's probably hyper on with dyskinesia. The absence of this has also been documented and well correlated to be as an absence of the dopamine withdrawal. That is, in the patient is no longer in the off state. So basically, beta oscillations is a very good biomarker for PD symptoms. Over time, we have identified that it's not just the STN, but also the globus pallidus, which can also give out these the local field potentials, both beta and gamma. And there is a very good correlation to both the appearance and the disappearance of the off state. And because nowadays technology is progressing quite well and quite alongside parallelly to our clinical knowledge, we are having easy, comfortable wearable technologies which can also sense this. So we've gone from just sensing it in the OT to providing adequate technology that the patient can wear it around in the IPG, and we can get real-time data beyond the OT period also. So the patient indications for an adaptive DBS are basically the same patients who are eligible for the continuous DBS, but most importantly, they have to undergo the adaptive DBS implantation. That is, the technology is slightly different for adaptive DBS. Also, in the last few years, many people may have already undergone CDBS before the availability of ADBS in India. So if they do have something called as a sensing technology, they are also eligible after the software is updated. Now, coming to the technical requirements, as I was saying in the previous page, the technical requirements are slightly different for ADBS. Going back a little in history, this is how our electrodes normally appear. This is perhaps one of the oldest type of electrodes that we all know as movement disorder specialists and neuromodulation specialists. Over time, this has been modified in terms of the number of contacts available, the space in between the contacts, the orientation of the contacts, as well as segmentation of the contacts to allow for something called as directional steering. Now, this is how, as if you recall, I mentioned about something called a volume of tissue activation. When the current is given, the shape of the electricity can be decided based on how many contacts or which direction you have stimulated in. So the type of stimulation can either be monopolar or unipolar, bipolar if two electrodes are activated simultaneously, or interleaving if they are activated in a rapidly alternating pattern. We can also have multiple level, or we can have directional. Now, what is most important for us is not only should the electrode be, when it's placed, not only should it have the ability to sense what is happening in the area and pick up the local field potential and send it back to the IPG, but it should also be able to have this bipolar configuration. All right. So if I'll show it further down the lines. So if you're trying to do the electrode sensing by keeping the activity in the lowermost lead, that may not be possible. So that is one of the disadvantages of this new technology. So going ahead, the technical requirement for the implantable pulse generator is not much. It should just be able to capture the sensing signals which has been sent to it from the electrode. But what it does also need is a bit of a software, which is basically it has to decide on its adaptive strategy. When it gets a signal, it has to choose a protocol by which it is able to give back a signal to the brain saying that the current has to be hiked up or hiked down. So there is either an on and off design, and as the name says, it is basically switching the current on or switching the current off depending upon a preset fixed setting of the local field potential threshold. There is also the gradual design and the continuous design, which again, as the name says, are gradually hiking themselves up. In the gradual design, the amplitude decreases or the increases are stepwise, whereas in the continuous design, there is a tendency to follow an incline depending upon how the input signals are coming. Now, I have to shift from more generic terms to a more, technical term here. I may have to, currently what technology is available is using the terms, the same three terms that I used previously, that is on, off, gradual and continuous design, is currently known as single threshold, dual threshold and proportional. So as I told you previously, if you have single threshold, based on whether this threshold is there or not, the current will rapidly hike up and rapidly fall down. Similarly, when you think about a dual threshold, these dashed lines here, these are the thresholds for the current to gradually ramp up itself along an incline. And if it's proportional, it will just follow this incline gradually. There are important differences between all three of them, which can be suitable for each patient depending upon the patient's presentation. However, the most important point that we have to remember is the temporal biomarker smoothing. So basically, if there is an response coming from the sensing device saying that the local field potential is elevated, in how early does the response come back from the IPG is different between these devices. So if you're having a single threshold, the response is almost instantaneous. It's like in milliseconds. But when you talk about a dual threshold, it is slightly slower. It is milliseconds to in minutes. And when it's proportional, it's slightly longer in terms of seconds to minutes. So this kind of makes a difference for the patient, both in terms of the good response as well as the side effect. So if a patient wants almost immediate response in terms of his tremor, probably a single threshold is the better option. But if it's an elderly patient who is affected severely by a rapid elevation in the electricity level reaching their brain, sometimes they can come back saying that they have giddiness or they feel a lot of tingling discomfort, then probably it is better to have something like a dual threshold. So currently in India, we have only one technology or one technological device which is offering adaptive DBS, which is basically the Medtronics, and they have used the term brain sense. So I'll be using this more often because most of the studies here forward have used the Medtronic device itself, and brain sense is nothing but their technology, the name that they have given to the technology of adaptive DBS from their end. So, as we all know, whenever we do programming after the conventional DBS or the continuous DBS, post the surgery, we generally wait for a duration of 4 to 6 weeks. The patient is called in. We do a brain MRI. We check the monopolar review, and then we place a lower threshold for the effect, a higher threshold for the side effect, and we decide on how the patient is doing, and then we call them back frequently, maybe once in 4 weeks, once in 2 weeks, before we finalize and we stabilize the program. Now, what happens when we decide to do ADBS in terms of programming is that the initial period is very similar to the conventional DBS. The patient comes in, the patient undergoes the assessment of their off and on symptoms, the UPDRS is placed, the patient's most severe symptoms are recorded, and then we place the CDBS itself. Once we place the CDBS for a short duration, we then assess whether the patient is also compatible for the adaptive DBS. If the patient is having compatibility for adaptive DBS, then we further go into the parameter assessment and adjustment. So this is a short flow chart which is from ADAPT PD trial. Same thing which I just told, but I'll just show this along with some examples. So when we do something called a brain sense survey, like I told you, we need a bipolar assessment for the brain sense survey and the timeline. Sorry. So what happens is two electrodes, when they are allowed to sense like this, they basically end up forming a montage. So here we can see that one electrode is at 2A level, the other one is at 0. And what they're doing is they're sensing in the area between them what is the local field potential. The same way, two leads in a two leads in an EEG end up forming a montage. So in this particular patient, which is actually a demo patient, probably the patient is in the off state, and we're seeing a very good beta peak. We are not seeing a gamma peak. We are not seeing a peak below the 13 hertz part because the patient is not having much of a tremor, and the patient is not in the on state with dyskinesia. All right. So this part is set up in the patient when the patient comes to the clinic. Now, once the patient has, we have set up the brain sense setup like this, which includes that this is the stimulating zone and these are the sensing zones. The patient is sent back home and asked to come back after a couple of days. All right. And when the patient comes back with something like this called the timeline or the tracker. Now, in the timeline, we encourage the patient to mark their events and even let us know how they are doing. And as we go ahead, we then use based on the events that they have told us, we use multiple markers. This is a very busy slide, I understand, especially for early individuals. It may be very confusing. But when the patient comes back, we look at what is known as the local field potential in the last few days. So particularly look at the brain sense streaming part of it. And what you will see is that there will be a lower threshold that you can set and an upper threshold you can set by identifying 3 days which the patient is able to identify as their average normal days. That is, neither was there a day of completely no activity, nor was there a day of excessive activity, which is generally falling towards the end of the Gaussian curves, the last 3% or the first 3%. So we avoid those days and we take 3 days which the patient has marked and we ask them to identify those 3 days. Now, in those 3 days, we see what is happening to the local field potentials. So in these 3 days, we identify in the timeline the lower local field potential, and we identify 25% cutoff of the beta power. And for the upper part, we decide as a 75% cutoff. So basically, we are trying to cover the intermediate 50% so as to identify the threshold. Okay. And this is in terms of single threshold. There is something known as the dual threshold. The single threshold basically is very similar to a dual threshold, except for the fact that the ramp time is slightly higher, and we will have to decide on the ramp time once we set the thresholds and the patient reports to us saying whether they have any complaints in terms of giddiness or in terms of abnormal sensations. So because these are all very technical terms, I thought it is better that we can discuss along with the patient's details, ongoing details. So here we have a case, Mr. SS. He's a 53-year-old gentleman. He basically has tremor predominant Parkinson's disease, which is left more than right. It's more in the rest as well as in the outstretched position also. He feels that there are some symptoms. As I was discussing previously, he qualified the 5-to-1 rule. He was having good response in terms of other parameters, but he was having disabling of symptoms. That is, his tremor was very problematic. Especially in the early morning, he would notice when the drug had worn off, he had painful dystonia of the left foot. There was a mild background history of psychiatric symptoms in the form of anxiousness and stress. And he underwent the bilateral GPI DBS in November 2025 with Percept RC with Sensite lead. Now, mind you, November 2025, talks were still on with the government, and we had still not been able to set contact points. So here you can see, based on those findings, we set up a stimulation parameter like this for him. So for the left GPI, we chose only the contact 1 because it had good response. For the right GPI, we chose something called interleaving, involving both the contact 8 and the contact 9 and contact 10. Now we tried other parameters also, which is basically, as you can see below all of these points, there is microseconds and hertz, which is basically the pulse width and the frequency. So you can see different numbers in different groups. This was the best group that we were able to identify in the initial, the conventional DBS or CDBS. But after a couple of days, we started, the patient started reporting back to us with some home videos saying that otherwise he was okay. The dystonia was better, the anxiety was better, but these kind of tremor-like symptoms kept coming back. And we thought of multiple possible lines of care, which was basically increasing the amplitude, which is a common thing we do when we see tremor that is not well controlled. Increasing in frequency, trying the interleaving, which we had also tried previously, trying something called the double monopolar, and also increasing the medication. So fortunately for us, we were able to get the approval from the government at the right time, and we were able to initiate ADBS in this patient. So when we did a brain sense setup, this is what the brain sense setup looks like. We choose two contact points. We choose a contact point which will be stimulating. So these green dots here are the ones that are sending out the signal to the brain at on the left GPI 1 milliampere, right GPI at 4 milliampere with appropriate microsecond and hertz frequencies. And these antenna-like signals here are the ones that are sensing and sending back electrical signals to the IPG regarding the local field potentials. So along with this, because he was also our first patient, we did something alongside. We asked the patient to look at what is happening in terms of the events himself also. And finally, we started doing the adaptive DBS setup on March 3rd. And this is what he came back to us with the timeline of the adaptive DBS. Sorry, one second. Yeah, so here you can see there are three windows. One is the left top is the left top is the left GPI, and right top is the right GPI, and below is a single threshold. As you can see, these dashed points here are the thresholds that we have set for him initially. Okay, the blue dash is demonstrating the upper threshold. The yellow dash is demonstrating the lower threshold, and all of this is describing the local field potential power there. The lower screen here describes about what is happening to the current. Okay, so we set up the threshold based on his initial values. And we also did an in-clinic single threshold. Like I told you previously, we run the adaptive stimulation, and we also see what is happening, and 25% below and 75% above are the thresholds that we set, whether it is dual threshold or single threshold. So once he was started on ADBS, he was sent home. He tried both the dual threshold as well as a single threshold. He was tolerating it well. And when he came back, this is what we see in terms of what is happening in the timeline when they come back with the threshold being activated. Like I told you previously, this gentleman predominantly had left-sided symptoms. The right hand was doing well. So when you see the lower part of this window, there is not much that has happened in the terms of adaptation by the system, because majority of it is below the upper threshold. Now, on the other hand, when you look at the right GPI, now you can see these pink dashes here. There is frequently an elevation above the set limit of 3.9, and this has been happening on more than one occasion. And every time this is happening, there is a concordant or a corroborative increase in stimulation or the increase in the sensing of the local field power. So this is what we see in the dual threshold window when they come back to us. So going ahead, he was doing quite well. Even the single threshold showed similar findings. What we did realize when he was on single threshold was that, especially early morning, he felt that some of his symptoms were worsening. And that was probably because of the ramping time. So Dr. Guruprasad had he was able to change the ramping time, was able to bring up the ramp time and gradually increase the current when he was on a single threshold. Following that, the patient may or may not have additional and above improvement over the conventional DBS if the patient is not already having too much fluctuation. So in the interest of time, I'll just be skipping the second case. And the current status of adaptive DBS is that it can be used in all patients who are having Parkinson's disease and are eligible for continuous DBS. They should just be having the appropriate sensing system implanted. In addition to Parkinson's disease, we are also seeing that local field potentials are being picked up in other movement disorders also, for example, essential tremor, dystonia. So it can be used in these conditions also. There is lesser details after sensing in terms of gait and freezing, whether it is in terms of Parkinson's disease or other forms of freezing. And there are indications even in the psychiatric domain for DBS, but we do not have adequate information in terms of the sensing thresholds for these disorders. So over the years, what we will see that there is going to be a slow transition from continuous to adaptive DBS, not just because of patient demand, but also about the simplicity, both for the clinician as well as the patient. Especially because it provides better on-demand control. The patient doesn't have to go around walking with the remote in hand, having 4 different groups saying one is for walking, one is for writing, one is for sleeping, one is for exercising. The system takes care of itself. The overall the requirement for the patient to step into the OPD for each of these symptoms, the number of times they come will reduce, the cost of travel will reduce, and similarly there will be fewer stimulation side effects over time, including speech and gait problems, which are very common nowadays. In our own experience, like I mentioned previously, it's very encouraging, but we understand that there are certain set of patients who will benefit, but there are other patients who may not benefit. We have to also remember that this is a learning period for even many of us as experienced neuromodulation neurologists and scientists also. So there's a learning curve, and we have to all be aware of the pearls and pitfalls as we are going ahead. And the key limitations and ongoing challenges in this area right now are that local field potentials, they correlate well with bradykinesia and rigidity, but they correlate poorly with other symptoms like tremor and freezing of gait. The programming complexity I've already discussed about. And there is also not adequate information in terms of long-term outcomes and generalizability, not just about PD, but also about other conditions. Going ahead, we're expecting to see that ADBS will spread its hands and it's going to start covering other areas also. We have to remember that this is a sort of a necessity in terms of taking our science ahead, but we have to also remember a lot of it is based on the parallel knowledge and also the creativity of our teams. And with that, I would like to end my presentation. This is our team from KIMS, and thank you for your attention.
Wonderful presentation, Sneha. So covered completely entire gamut of how it started and what is the likelihood of what is the expectation and what is the future. Dr. Josna, how much time do we have for discussion?
So I think 2 to 3 minutes should be okay.
Okay.
Uh,
I'll just have a just a mark, and then we'll probably take a couple of questions. So, as I said, every technology comes with a challenge and limitation. For want of time, I think Dr. Sneha didn't cover what is the technical limitation in ADBS is that we can't go beyond a point in terms of frequency. So the frequency allowed is around 240, 250 general in CDBS, whereas here it's allows only in 185 hertz. So we can't go. Someone has, like this gentleman had a lot of tremors. The latest frequency we used before ADBS was 220, but we had to settle for 180 when it comes to that. And then when there is interleaving, when we're using two contacts for stimulation back to back, we can't use that in ADBS. So that's a little technical limitation, but we can overcome with adjusting the threshold and also that can be, as I said, there's a learning curve. So why it is required, why CDBS is required is that what the paper adaptive DBS showed that it reduces at least 50% of energy consumption. So the battery life will get thing. And there is an unnecessary the stimulation of the area, because for example, simple thing is in the night when the bradykinize rigidity is less, it will adjust, it will the ramp it down, the current gets ramped down, and the amount of stimulation done, it automatically comes down. So unnecessary stimulation of the area. We know that there is a chronic stimulation related side effects related to whether it is motor or non-motor, complications related to chronic stimulation. So that is known, that is shown to be reduced. So we have a more personalized and what do you say, adjustable stimulation happening, and it also in the long run it also reduces the battery energy consumption. So that is the looking at the thing, and then people who fluctuate in a day also gets helped. So single threshold, double threshold, in the trial didn't show much difference, but there are certain set of patients who will benefit, who have rapid fluctuations can benefit single threshold because the switchover is very fast, whereas in people who have slow fluctuations, a little bit of more dyskinetic, they are benefited with dual threshold. So with time will tell which will benefit which patients. So now we can probably take a few questions related to the topic. Is there any questions on the chat box? So meanwhile, as Dr. Josna is looking at the chat box and looking for questions and all, so we had some experience now. We have implemented around ADBS for around 7-8 patients, because we've been preparing these patients for adaptive DBS. We've been telling these patients because there's a new technology coming in, so we've been using implanting sensing lead. Basically, you required that. So as Dr. Sneha said, who are the candidates eligible? Every DBS patient who's going for DBS, Parkinson disease patient, is eligible for ADBS. But only thing is they have to have the hardware ready for it. So someone has a sensing lead can be ready for it. In fact, they say that even the conventional lead also can do that. They need a little software update, but better to be prepared and things. So we have some experience of implementing for 7-8 patients. We have a mixed result. Some people, I mean, some patients right away didn't tolerate it because of the nature of CDBS they were in. We couldn't reciprocate the same thing in ADBS. Somewhere on very on low stimulation could adapt DBS well. So we need to look at which other patients will benefit and then take them along.
So I couldn't show the video of the second patient actually, but I think what we had been able to do was we were able to smooth out her day. Her
Yeah,
quality of life improved because the
yeah.
midday wearing off which she used to experience, the medication and the balance we had been able to achieve between the medication and machine, that we were able to further fine tune and sort out. So
And
that was
also
one of our
because she had a lot of apathy and poor
yeah.
motivation, that also improved, because I think the stimulation what was not required during the on state
When,
was minimal. So I think that also improved. So it also has effect on both motor and non-motor symptoms.
um,
Right. Thank you so much, sir and Dr. Sneha. It was a brilliant presentation. And we are taking things a notch forward in movement disorders. The finer intricacies you explained very well. We are really grateful to you for sharing your clinical experience and expertise. So, there are a few questions, but I do not want to disappoint the youngsters who are waiting to present. I would request Dr. Sneha to see if you can answer it in the chat box. If it is not so, we can take it in the end. Is it okay?
Yeah, absolutely. No problem. Thank you.
Thank you, sir. Thank you, Dr.
Thank you.
Sneha.
Thank you. Thank you.
Thank you so much. Bye-bye.
So we move on with the next presentation. To moderate this session, we have a young neurologist, Dr. Srinivas UM. He is a consultant neurologist at Apollo Specialty Hospitals, Chennai. This is not actually his profile. He has got a brilliant profile, but then if I go into that, it'll take a lot of time. So in the interest of time, I invite Dr. Srinivas to introduce Dr. Sanjana and moderate the session. Welcome, Dr. Srinivas. Thank you for being with us today.
Thank you, Dr. Jyotsna, and thank you, Dr. Saraswati, for inviting me and having me part of this session. We have Dr. Sanjana DS from Bangalore Medical College, who's going to be presenting a very interesting case of movement disorder. I think I'll just hand over to her and go ahead with the discussion in interest of time. Yeah, over to you, Dr. Sanjana.
Thank you, sir. At the outset, I would like to thank IN Young Neurology Forum for giving me this opportunity. Today, I'll be presenting a case of a 25-year-old female who has done BCom. She works as a business operation analyst, hailing from Bengaluru. She is a right-handed individual. The information is given by herself and her mother. She has come with a chief complaints of imbalance while walking since 2 to 3 years of age, clumsiness of hands since 5 to 6 years of age, slurring of speech since 5 to 6 years of age, and difficulty in swallowing since 8 years. Coming to her history of presenting illness, she was born out of normal full-term vaginal delivery. She cried after birth. There was insignificant perinatal history, but however, there was a motor delay that she started walking late at the age of 2.5 years. She was slower than her peers, and she had a hard time keeping up pace with them, and she was unsteady and had frequent falls. She would have difficulty navigating narrow passages in climbing stairs, getting up from squatting position as her childhood progressed. And since the last 5 years, her imbalance has worsened such that currently she is able to walk independently for a short distance in familiar spaces, but she requires constant support when she walks outside, especially while turning, climbing, and squatting. She also has clumsiness of hands since 5 to 6 years of age, which was noticed first in the form of difficulty in writing and typing at her workplace due to her clumsiness of her hands. She has speech disturbances since 5 to 6 years of age. She drags the words. There is undue gap between the syllables. At around 13 years of age, people were unable to understand what she speaks on the phone and would often ask her to repeat herself. In the last 2 years, it is worsened such that in her workplace also the colleagues are unable to understand what she speaks, which has interfered with her work, and she was terminated from her job. She has swallowing difficulty since 8 years, such that she has choking sensation in the throat when she tries to eat fast, which is there for both solids and liquids, especially when she tries to drink water from bottle held high up. She also gets nasal regurgitation when she tries to eat fast. There is no tremulousness of the hands or involuntary movements. There is no any eye movement abnormality in the form of head thrust or difficulty reading books. There are no other visual disturbances. There is no memory or cognitive disturbance, no hearing disturbances, no bowel bladder disturbance, no sensory symptoms, no history of any weakness, thinning of the limbs, stiffness or heaviness of the limbs, and no history of night blindness. Coming to past history was not significant. Family history, she is, as you can see here, she is born out of third degree consanguineous marriage. Her father married her aunt's daughter. She has an elder sister who is 1 year elder to her. She is also married, has a kid. Neither her nor her child is affected with a similar disease. Coming to personal history, it is menstrual history is normal. She consumes mixed diet with good sleep and appetite, unaltered bowel and bladder movements, and with no history of any alcohol consumption, smoking, or any drug abuse. So I'll summarize, sir. So at the end,
Yeah. So,
yes, sir. At the end
go
of
ahead.
history, she's a 25-year-old female who's born out of third degree consanguineous marriage, who has come with childhood onset chronic progressive walking difficulty, which is cerebral ataxia with incoordination, dysarthria, and dysphagia. with all this taking into account, I would like to consider pancerebellar involvement. As we can see here, this is a cerebellar homunculus. So as we can see, the truncal area and the head is represented in the vermis, whereas the appendages, the upper limbs are in the paravermium and the hemispheres. So if you take gait ataxia, we can localize it to the rostral vermis. And we have the limb incoordination, which can be localized to the cerebral hemisphere or the neocerebellum. The speech and the swallowing difficulty can be vermin and paravermial. So at the end of history,
So, no, 1 second. Before you move on,
yes,
I want you to just say, so you have a summary now.
yes.
What is the predominant syndrome from this history? In movement
Cerebral
disorders, we always talk about syndromes. So what is the syndrome that we are looking at?
chronic cerebellar ataxia, sir. Childhood
So
onset
it's a
chronic
chronic
cerebral
syndrome.
ataxia.
Childhood onset, probably autosomal recessive. Can you
Yes,
call
sir.
that from your pedigree chart? So you're assuming it is inherited. So
Yes,
given that it's the duration, so
yes,
it's
sir.
now what? It's been going on for the last 20 years now. So it's been
Yes.
a chronic, progressive, and pure cerebella, or do you think anything else is attached?
With the history, with associated symptoms, I
Anything
would
else from the
like
history
to.
that you think?
No, sir. I would consider pure cerebellar syndrome
No,
only.
no,
All
from the
the
history, pure cerebella. Anything, nothing at all in the history suggest anything that you think is probably significant or anything like that?
sir,
So what was, I
associated.
mean, there was, go back to the, I mean, I just want to check a couple of things when you were mentioning. Um,
Yes,
so you were talking that you were telling me, can you go back to the history, the first to
yes,
second slide, I think, second slide. Yes, yes. So
yes, sir.
the first thing you mentioned was the imbalance. Imbalance
Yes,
was
sir.
the major problem, isn't it? And
Yes,
then so it started with imbalance and then went on to uh, ataxia. So went on to dysarthria. So it started
yes.
from imbalance and then went on to dysarthria. So probably are you going to say this is Burmese, or you want to say Paravermian first? It's probably started with Vermian, isn't it? The history wise, if you want to take it that way.
Yes, sir.
If it's an imbalance, is a major issue that you're having.
Yes,
Uh,
sir.
yeah. And other thing I wanted to ask you is, so you said slower than peers. So slower than peers is only that issue. Was it just that ataxia, or do you think there's anything else? Was there anything else in the history that suggested, oh, it's
So,
something else?
yes, sir. So
You have been
imbalance.
looking at some other association. Yeah.
So any other movement disorders like any dystonia or any other involvement also can cause difficulty in walking. But however, her major symptom, as told by the mother, was swaying. So there was no abnormal posturing
Playing.
of the limbs.
Right.
There was any movement
Okay.
abnormalities. If you're thinking in terms of any
Ah,
cerebral palsy, so
right.
it was more of
Ah,
fitting into cerebral ataxia.
okay. And you also mentioned that. So, what was the last point? So, she walks independently for short distance. No, that's the last point in the same page. In
Yes, sir.
familiar spaces. So, what is that telling you?
So the thing is, because it's a long-standing disease, because she's acclimatized to her places, so especially when they go out to the crowd, they'll have increased instability, the fear of falling increases. So because at
Mhm.
home or in a familiar places, at home she's able to manage. But however, when she goes out, especially when she has to turn where she requires balance, then she's having much of
Mhm.
difficulty. That is what I wanted to tell, sir.
And I mean, the climbing, squatting, is there any weakness that is there? Any proximal weakness that may be
No, sir.
causing
No,
that?
sir. No, sir. There was no any history suggestive of any buckling of knees. There is no any ankle instability in the form of wobbling at the knees or there is
Okay.
stiffness. So history-wise, it was not there, sir.
It was history-wise nothing there.
No, sir.
Okay. So I think we'll just stick. Yeah. So it's a pure cerebella. That's what
Yes.
we have, isn't it? And we say cerebella, we say ataxia. So if the patient has a
Yes,
pure
sir. Yes.
ataxia syndrome,
Yes, sir.
and any chance that could be peripheral ataxia that is causing all of this, or we think only central?
Peripheral as in you think vestibular or sensory, sir?
Vestibular or
Uh,
sensory, yes.
Yes, sir. So vestibular as in they can have even they can have imbalance, but they can have any other ear symptoms like any tinnitus or vertigo, which was not in this history. And sensory symptoms were not there in the history. And also sensory ataxia, we can ask in history whether they're looking down while they're walking. Such history was not very upcoming, sir. And with associated other symptoms with cerebellar like dysarthria, dysphagia, I thought it is more of a cerebellar syndrome.
I mean, to be fair, just to add on to that, in a vestibular ataxias, you might not have vertigo, you might not have tinnitus or hard of hearing.
Yes.
Especially if there's bilateral involvement, you will not have vertigo. So vertigo might it's not necessary to call it vestibular. Uh, I mean, the questions that you're having that the positional changes, especially when she's turning, she needs support, she tends to fall. That is actually quite that this means that yes, quite possibly there is some vestibular component. Whether it's central or peripheral vestibular, we do not know. The
Yes.
vestibular cerebellum is affected, you are going to have the same problem, isn't it? So again,
Yes.
so when this turning and she's playing, and especially this worsening in unfamiliar places, usually that means that the sensory central integration is bad. So I mean, new sensations and integration is quite bad. So it might be because of the vestibular system. The vestibular system might be affected. So could be a vestibular cerebellum. If you're going to test all of this central, yes, vestibular cerebellum, or could be some associated bilateral vestibular involvement as well. We still do not know, but again, that we will have to add on in the clinical examination. So again, that's something to probably keep in mind. And regarding the sensory, many a time we do not get the history of looking down or any of that. But is there anything that suggests worsening in darkness, eye closure worsening, anything like that? And
No
the
history, sir. No
patient
such
sign, the
history.
classical patient. Yeah. So those all signs that will tell us whether it's more peripheral or more central. Again, if you don't have that history, yes, it helps us go point towards a more central cause of this ataxia. So the syndrome we have right now is a pure ataxic syndrome, which has been progressive since and onset in childhood and progressive over the last 20 years.
Yes,
And
sir.
if we are thinking more likely central, and do we call it pancerebellar,
Yes, sir.
or do you want to call stick to only spino and I think the
Because
summary you've given is spino and neocerebellum.
pancerebellar, because there is ataxia, which can be Vermeer involvement, and incoordination is more of a neocerebellar symptom.
Hmm.
So, or paravermin or neurocerebellum. So,
Yes.
with history also, it looks like pancerebellar.
Okay. And that's interesting in that. Can you go to the dysphagia part, please? You had discussed about the dysphagia. You had mentioned, yeah. So you mentioned the choking sensation,
Yes, sir.
which is present only both solids and liquids. How are you going to interpret this?
So
How do you
basically,
like
if
to interpret this?
yes, sir. Basically, if you have more for solids, we can think of mechanical any obstruction. Also, when she with history, when I asked, I have not mentioned here. The thing is, she was able to make a bolus of food. She's able to push it against the palate and swallow. But however, these gets aggravated when she tries to take it fast. And it is known that cerebellar disease aggravates when you try to do a fast. So that's why I meant to say it is cerebellar more than any other neurological cause of dysphagia. Cerebellar than any
And
other.
so what do you mean? You're thinking more of cerebellar. Could it be spastic?
Um,
I mean, even the spastic, when you try to eat fast, and especially in pseudobulbar effect, people with pseudobulbar palsy, they do tend to have aspiration. They do have choking sensation as well. Was there any aspiration at all,
no, sir.
or
She
nasal
told me.
regurgitation?
No, sir. No nasal regurgitation. She specially tells that when she tries to drink fast or eat fast, she gets this symptoms of choking and nasal regurgitation. Or else other times when
Choking.
she slowly eats,
No, no, man, that's my question, isn't it? So, okay, how can you tell me if this is due to a spastic dysphagia or a cerebellar? Even in a spastic, if you're trying to do it fast, you will have quite a significant high chances of choking and aspiration as well. Sometimes very difficult to differentiate. But I think what you're trying to tell me is that if she's trying only focus on with only if she's eating fast. So when you take the spastic dysphagia as well, they don't have nasal regurgitation commonly because the palate is active. It's actually overactive, isn't it? Everything is overacting in spastic dysphagia. So your palate is actually moving well. It's when the palate doesn't move that you're going to have this regurgitation. Whereas choking can occur because if everything works together too fast, yes, you can get choking. Regurgitation usually goes against the human type of human cause of the dysphagia, whereas choking is much more likely if there's a bulbar weakness per se. Um, did they have regurgitation or not? I think that's a good question.
She told she has nasal regurgitation, sir, when she drinks sometimes, especially when she drinks fast. She did tell that.
Mhm. So you're thinking it's more of incoordination rather than spasticity
Yes, sir. Yes, sir.
between the muscles. Okay,
Yes, sir.
fine. Okay. I think that's something which might, so we still do not have anything to suggest uh, spasticity in this patient, purely
Yes,
cerebellar
sir.
still.
Yes, sir.
Okay, yeah, fine. And the speech, how do you want to characterize the speech?
A speech, basically, she's able to understand and reply correctly. There is not a language problem.
Mm-mm-mm.
But when she is speaking, there is the prosody is gone. So that's why she drags the words and there's undue gap between the syllables. And it has progressive also with the history. We can tell that gradually over the phone, people are not able to hear what she's speaking. And in the last 2 years also, our colleagues in normal conversation also are not able to discern what she's speaking. So with the
Okay,
history, I felt like it is more of cerebellar. If for spastic, it would be
cerebellar.
explosive, like one syllable moving into one another. If it is
Mm.
spastic,
We can also have a cerebellar, what we call staccato speech, isn't it?
it's explosive. Yes.
Yes, yes. So explosiveness can also occur in cerebellar. So sometimes it is quite hard to differentiate unless you hear for it yourself. We have very distinctive features when we listen to the speech. But I think yes, maybe. I just put a question mark in that maybe. But again, here now since you said she's dragging, we're thinking more of scanning. So cerebellar
Mm,
much more likely.
mm.
So we are still sticking with cerebellar, pure cerebellar syndrome, something uh, early onset, progressive. That's it. Okay.
Yes, sir.
And nothing else, and no bowel and bladder, nothing else to tell
No,
us
sir.
that there is any other syndrome, any other system involved neurologically or anything else. Uh,
Yes.
Again, given the presentation, would this be CP? I think that's something we need to rule out because that's the most common misdiagnosis that happens.
Mm. The thing
Could
is,
this
one
be
more thing
cerebral
is,
palsy?
yes, sir. History-wise, perinatally, it was uneventful. Also, other
Mhm.
milestones were normal according to the mother. It was only the motor part, the balance part is what is affected.
We do
So,
have a cerebellar CP. We can have
yes,
ataxic CP, isn't it? Ataxic
yes.
CP is an entity that
Mm,
exists.
mm,
Uh, I think the bigger question is CP is usually static.
mm,
When you tell me that the symptoms are worsening over the years,
mm,
that kind
mm,
of takes away diagnosis of CP. People can mistakenly assume that it's progressing, but usually what happens is that as the
mm,
child gains milestones, the symptom comes in. So when your
mm,
patient is sitting, you don't know how their speech is, their walking is going to be. So they can't say, "Oh, she was crawling the ataxic, then she started developing the ataxia when walking." That's only means she started to walk and she's developed difficulty. So that's usually what happens in CP. When the disease is progressive, you're telling me the dysarthria has gotten worse over the years. It kind of makes me think less likely that CP is less likely. CP
mm,
is a static event. Anything progressive, it's definitely not CP. It's a single insult, isn't it?
mm.
So yeah, okay. So yeah, I think sir, group research, sir, anything you want to add on before we finish the history?
Very good presentation and all. I think what
Mm.
Dr. Srinivas is saying, I think it also comes to differential diagnosis. Like now, when you talk about vestibular, so there are, you will be talking about, cerebellar syndromes, which will go with vestibular. So vestibular cerebellum syndromes, even the autosomal recessive syndrome. So you need to capture that history. That's important. Vision. Is there any other thing? And also, I think. When someone has swallowing difficulty, so much florid swallowing difficulty with nasal regurgitation, I think brainstem involvement has to be thought of. Only pure cerebellar syndrome having so much of speech and swallowing. If it is only speech, I can understand. And if someone can't understand on phone, it can't be only cerebellum. It has to be probably either pyramidal or extrapyramidal. So I think, is that because it ultimately tells about hyperphonia. Hyperphonia is not equal to cerebellum. So it has to be either, I think you can also specifically ask them whether there's a strain, there's a hoarseness. So you can also come to, which part of the brainstem is involved. So I think probably your localization has to extend beyond cerebellum, I think. But I think, overall good. So wait for the examination findings. I think.
Yes, sir. As I think, unfortunately, they created the box of cerebellum. So history seems to fit only into that. So we'll have to wait for the examination to
Yeah,
see what
yeah,
else we
yeah,
have.
yeah,
Yes.
yeah, yeah, yeah.
All right, Dr. Sanjana, I think we can go on. I think
So
we'll
the
skip the differentials for now. I
okay.
think we'll skip the differentials for now.
Okay.
We'll go directly to the examination. Yeah.
So only the positive points I'll tell, sir. Examination wise, the vitals were stable and height, weight, and BMI was normal. Neck to height ratio was normal because I was thinking of a cerebral recessive ataxia. So we specifically look for any short stature. There was no short stature lipoma or any kyphoscoliosis, cataract, telangiectasia, particularly no cave ring, no tendon xanthoma, skin pigmentation. But however, there was hamartos and pes cavus, as you can see in this picture. And higher mental function was normal with Mocha being 30 by 30. Her speech here.
One second. I'm just going to pause you 1 second. 1 second, Dr. Sanjana. The hammer toes and
Yes,
pes
sir.
cavus, the patient did not complain any history at all.
No, sir. No, sir.
No difficulties wearing slippers, holding on to shoes.
She didn't give history, sir. I've asked. She didn't give
Did
similar
you or did
history.
you ask? Okay. No slippage and
No,
tripping when walking.
sir, have written as no weakness. So basically, I asked those also. She didn't give such
Okay.
history, sir.
Okay, that's unusual. Usually people will have a bit of symptoms with that. Okay, go ahead. So yeah.
So higher mental function was normal with Mocha being 30 by 30. The speech, I'll listen.
New Delhi, October 26th, the Indian junior men's 10-meter alarm rifle team missed out on a shot gold and an Asian shooting championship junior record. When one of the three marksmen, Dhanush Srikanth, was disqualified from the competition in Changwon, Korea Thursday due to improper stiffness of the apparel that he was wearing during competition. The Indian team comprises Umesh Martinez, Tanush and Abhinav Swa shot 6 to 8.5 and 6 to 5.6 to
Sanjana, you can describe the speech as she is
158
speaking. You
Yeah.
can probably,
which
Yes.
Yes, sir. So there's like spastic and ataxic quality both are there to the speech, sir. But there is spastic component also. And also she was dragging the speech and also there was
Predominantly
some
scanning. Predominantly scanning. So her speech is extremely drags out. She's dragging out syllables as she speaks. There's also a bit of she's getting breathless as she's speaking. That is probably the spastic quality coming through. So I think ataxic more than scanning, more than spastic. But yes, there is a bit of breathing difficulty that is happening when she's speaking as well.
Hi, Dr. Ela here. I wanted to ask something like, is this a standard way? How do you assess speech in your institute, or are there any specific methods which you would like to examine in like certain words or phrases when you're testing for ataxic speech?
actually we should see for specific syllables like linguals, labials, palatals. But I we just did a basic speech examination, ma'am. I have not put a video where we have assessed each syllables. Palatals.
Yeah, you're right. You're right that you specifically assess the linguals, labials, and gutturals, but that is the general examination of speech, which you rightly said has to be done. But because you have set the entire narrative to go in favor of now, basically what you have told us is there is lot of cerebellar findings that we are expecting, and so then there are certain phrases which you test, like in the English speaking population, you can use something like British Constitution or Chakravarti Rajagopalachari. These sort of phrases are tested when you want to test for cerebellar function.
Yes, ma'am.
And ideally, they should have removed the mask while doing it. It would have been nice to see how the lips are moving as well. It would have been helpful. All right.
Because of the identity, we want to not.
Okay.
Okay.
You can take just a voice note, please. That should be only the speech. Okay, fine. I agree with Dr. Ila. I think, yeah, thanks for pointing that out. Should have been a better video. But either way, so what we are seeing is, yes, the speech is involved, significant dysarthria. Yeah, if we move on, I think we're taking a bit of time. We'll move on.
So coming to clinical examination, the first olfactory nerve was normal. The fundus was normal, sir, like right and left. And coming to the extraocular muscle movement, the primary gaze position, there were no any saccadic intrusions. And all the cardinal position of gaze, all the movements were full. So coming to the positive findings, in this video, we can see there is gaze evoked nystagmus with broken pursuits. So here, and she's.
Over the saccades, doctor.
Sir, I'm playing the video of that also, sir. Next video.
Yeah.
Hypermetric, they were hypermetric. So there was basically gaze evoked nystagmus and the pursuits were broken. The saccades are both the vertical and the horizontal saccades. There was hypermetric saccades, sir. Pen. Camera. Pen. Camera. Pen. Camera. Pen. This is the vertical saccades. Camera. Finger. Camera. Finger. Camera. Finger. Camera. Finger.
Camera, finger, none finger, camera, finger, for Sanjana. Sarinama, camera, finger, camera, finger, camera, finger.
So they were hypermetric saccades, sir. I hope it was visible.
The video, unfortunately, I could not make out. I hope others could make out. The video is too slow for me to make out the saccades properly. I hope others can see it properly. I'm not sure.
Yeah, I think the speed of the video, no, that the hypermetric is not coming out. So that's okay. You can probably proceed. That was your
that's fine. That's fine. We will take it. Yeah, I will take it from as an objective finding.
And yes. Both vertical and horizontal was impaired, sir, absent.
Absent.
Yes, sir. Like there were no they were very impaired, sir. I can't say absent, but they were not saccades and pursuit were not well seen.
No, so when you're talking about okay, there are two components, isn't it? So which you are saying me both the components are impaired? Both the saccade and the pursuit is impaired, or just it is just reduced in amplitude, both they slower, small amplitude.
Reduced in amplitude, sir.
Reduced in amplitude, okay.
Yes.
Because you told me we have hypermetric, so you can't have hypermetric saccades and then absent okay. That doesn't fit. If you're hypermetric, I can understand. Simply showing a 5 movement, something is just very hard to make it out. Yeah. So probably the pursuit was slowed. Yes, that I can understand. Pursuit was broken. Yeah, again, I think the video unfortunately is not great enough to make out. We'll move on to them. So that's all right.
Yeah. So the motor examination, the positive findings was this was spasticity, greater spasticity in the lower limbs. Power was 5/5 in all the 4 limbs. Reflexes, upper limb was normal 2+. So knee reflex was exaggerated 3+. Ankle reflex being absent, and plantar reflex was bilateral extensor. Sensor system examination, there was impaired vibration sensor.
What about the doctor? 1 second.
Yes, sir.
1 second. What about upper limb plantar equivalence where they tested?
Equivalence,
the Hoffman, Wardenberg, Hoffman.
I have checked that, sir, but have not mentioned here. It was normal, sir.
Normal. Absent. You mean to say that?
Absent, sir. Absent.
Yeah. Okay. Yeah, Dr. Ella, it's yeah.
Yeah. Can you comment about the head impulse test?
Head impulse test, I didn't put the video, ma'am, but it was impaired, ma'am, because VR was also impaired. Head impulse test was positive.
So what is the significance? Like when do you say it is positive? Especially in the context that you are saying that the ankle reflexes are absent, there are hammer toes.
peripheral vestibular apparatus, peripheral vestibular apparatus, when it is involved, head impulse test will be positive. Basically, when you make the patient sit in front of you and make a sudden thrust of head to left
No,
and right,
no.
they will be.
And Dr. Sanjana, I think Dr. Ella is asking, in this
Yes.
particular patient, why is it significantly important? That given the clinical picture that you have given us. And we also spoke about the vestibular probably being a part during history, given that the turning again was significantly affected and the
Yes.
worsening in unknown places. I think vestibular, if you're saying me that the head impulse is positive, it adds on something to the diagnosis. Your syndrome is now changing, isn't it?
Yes, sir. It can be it can happen in any systemic involvement, other causes of autosomal recessive cerebellar ataxia, like any canvas where it can have vestibular reflexias, and it can occur in mitochondrial disorders also. And hearing impairment, or sorry, other systemic involvement, sir, not purely cerebellar. It points to that.
No, so so you're telling us, so if the head impulse is negative, but again, you did tell me that your saccades are hypermetric. So
Yes, sir.
so you cannot explain that if you have a very absent eye movements, yes, I can understand if your head impulse is negative. Or if you have a severely hypometric saccades, we can have a positive head impulse test. But these are hypermetric saccades as documented by use. But so if that is cannot be attributed to the cerebellum, so we have to assume that is associated vestibular involvement as well.
Sir,
So I think
cerebellum,
that's something we have to add on.
So cerebellum also has a role in vestibular ocular reflex gain amplitude. Specifically, the fastigial nucleus and the oculomotor vermis is involved in the amplitude, the gain, and the velocity storage mechanism in vestibular ocular reflex. So it can be cerebellum and also the peripheral vestibular apparatus.
So you're talking about the vestibular ocular reflex. The head impulse test only the fast reflex. So the head impulse test is an excellent bedside clue to differentiate central and peripheral. When you have a positive head impulse test, we have to assume it is peripheral.
Yes.
But we have to assume it is peripheral unless proven otherwise.
Yes.
Okay. So we have to assume there is some peripheral vestibular involvement as well. And I think Dr. Ella was pointing towards the possibility of canvas, given that you have absent reflexes in the lower limbs as well.
Yes.
If I'm not mistaken, but yes. And given that this picture, yes, we have to assume canvas is now in your part of the diagnosis. Let's see what happens. Yeah. Okay. Yeah. Please go ahead.
Yes, sir.
Yeah.
The cerebral system, bilateral cerebral signs were positive, sir. I'll just play the video. There were bilateral finger nose chase test was positive. There was so there was bilateral finger nose test was positive, sir. Coming to
I think we'll take that. We'll go on.
Yes, sir. Dysdiadochokinesia was present, and also the check rebound phenomenon was absent. That is, there was impaired check response. So I'll be playing the video of the gate, sir. So basically, here we can see there's a wide-based stance, and she's swaying to either side when she's walking. Also, the spastic component, and when she turning, there was a swaying to the left side, and also she's also looking down when she's walking. So I feel there is some cerebellar component also, spastic component, and some sensory component also. So to the
did you test the Romberg's?
So Romberg's actually it was positive. Romberg, the thing is she was not able to keep her legs together because of the imbalance. But however, when she stood steady and I asked her to close the eyes, there was worsening of the imbalance. So Romberg's was positive, sir.
I think that should have been a part of your sensory exam as well. Okay.
I have mentioned it.
So yes, Romberg's. Yeah. Okay. Fine. So Romberg's with the broad-based gait is when it's positive. Yes. So that is possibly some distal sensory involvement as well. Okay. So now your syndrome has now evolved, isn't it, from a pure cerebellar? We now have other symptoms, other systems involved now. Yeah. Go ahead.
So other systemic examination was normal. Summary. So based on that, a 25-year-old female born out of third-degree consanguineous marriage, she is presented with childhood onset gradual progressive cerebral ataxia with incoordination, dysarthral limb spasticity, and neurological deficit. On examination, we got gaze work nystagmus, eye signs basically with lower limb spasticity, extensor plantar, impaired vibration. And anatomical site, I would like to localize to pancerebellum with the corticospinal involvement and posterior column involvement. Because it's a long-standing disease, the pathology is most likely to be degenerative. And etiology.
Before 1 second, doctor, did we mention about the extrapyramidal examination? Was there any bradykinesia, any dystonia that was there?
No, sir. In
Mild
the history,
athetosis?
in the history,
Examination,
no, sir.
examination.
I didn't mention that in the slide. But
Yeah.
there were no extrapyramidal findings, sir.
You haven't, so you have not mentioned in the findings. Okay, fine. But was it examined? Was there an associated dystonia or anything of the sort?
No, sir. I mean, in the history and etiology, it will help in diagnosis. But in this case, she didn't have any of the extrapyramidal symptoms. Like if you're thinking of any ataxia telangiectasia or ataxia with oculomotor apraxia, and we also have to think of Wilson's disease also. They can also have extrapyramidal symptoms. So, but she didn't have extrapyramidals
Yes.
on examination.
What about any pseudoathetosis in the upper limbs? Was that checked for?
Pseudoathetosis was not there, sir. I
Okay.
didn't mention
That
it.
will also
Yes.
help us, isn't it? Yeah, that's something that can be helpful as well. That's a quite significant posterior column involvement. Can also help us. Yeah. Anyway, go ahead.
So etiology, because of this syndrome taking into account, I would like to think autosomal recessive cerebral ataxia. We should think always Friedreich's attacks also because it is the most common autosomal recessive cerebral ataxia, and a close mimic of it, which is ataxia with vitamin E deficiency, and ARSAC, which is autosomal recessive spastic ataxia of Charlevoix-Seguini type, and also spinocerebral ataxia, which can usually it is autosomal dominant, but some of it can present early childhood. So these were my differentials at the end.
You can also have incomplete penetrance in many patients. So that's something which can be the reason for autosomal dominance. So we can't directly rule them out. Yes, autosomal recessives are much more likely. Is there anything else that you want to think about? Do we want to add in the vestibular system? Given that you told me the head impulse test is positive, they did have a catch-up circuit. If they have a catch-up circuit, do we want to add it in?
Yes, sir, I can add it. Thinking cerebellum also can be. So I can include it as a part of cerebellum only. I mean, but
I'm still not. I'm not inclined to accept that. I would like to invite some others as well. But
okay.
if I get a bilateral head impulse test positive, it's just very hard to assume just the cerebellum causing a positivity. It's very extremely unusual. So,
I
Guru
fully
Prasad,
agree,
sir?
Srinivas. Fully agree, Srinivas. That is
Yes, sir.
actually telling about peripheral vestibular.
Yes,
So,
sir.
I mean, that's what we differentiate. It's a important test for us to differentiate in central and peripheral. When there's a positive head impulse test, it goes towards peripheral. Uh, whether it is nucleus, tract, or no, it becomes more peripheral. And also, you also have another finding of one more finding, no, the VOR, VOR or this one. That is also
We
OCAN.
are.
OCAN also you said. So that also you should include. Na?
Okay.
That
Yes.
also comes to tells
Yes.
about peripheral vestibular. So I think that is a very
Yes.
important part of it.
Okay.
And
And
one more
again,
thing I was
sometimes
saying was the fundus. I felt that the left side optic disc
Correct,
was
correct,
very pale.
correct. Pale, pale. Yeah, I also felt so.
I mean, I think it might have been the quality of the image, not for the, or maybe I don't know. We don't know.
No,
I
sir.
think
Actually,
But
it was a little
both,
out of focus.
I discussed with the ophthalmologist. We got
Yeah.
it. They have a Canon machine where they'll have a DSLR camera where they are flash artifacts, sir. I discussed with them. Even I thought it is little suspicious, but they told there is it is fundus is normal because of the flash artifact is what they told.
okay, fine.
Can I move ahead, sir?
So so again, I think the question is, and sometimes if you're worried about the VOR, you can also do a VOR suppression test to differentiate peripheral and central.
Okay.
That's a quite easy test to do on the bedside as well. Extremely easy to do at the bedside. Takes like 5 seconds.
Okay.
So any idea how you do the VOR suppression
Yes,
test?
sir. The swivel chair test, sir. You make the you make the patient sit and make his hands outstretched in front of you. They should be focusing on the thumbs and
Okay.
do a rotational movement. So if your vestibular reflex is intact, there will not be catch-up saccade that is noted. That is bedside examination to look for VO suppression, sir.
So what does it tell you if you can't suppress the VOR?
It is normal, sir. It's a normal phenomenon.
No, but what does it tell you? Is it central, peripheral?
Central.
Yes. So VOR suppression, if it works, it means it's not central is normal. So basically, if you cannot suppress the VOR, it means there's a central pathology, a cerebellar pathology usually, or integrating nucleus pathology. Whereas if you can definitely suppress the VOR, your central pathway is intact. So your central pathway is what maintains your fixation. So when you're
Yes.
doing the VOR is a peripheral reflex. Do not remember. Yes, we have an integrator in the cerebellum, but it is actually a peripherally induced reflex. So if a VOR, when you move it, yes, the VOR will happen. But if you can maintain the focus, that means your central pathway is actually working very well. The VOR suppression test, I mean, here I expect it to be abnormal. If you had done that and told me, yes, the VOR suppression is abnormal, central disease, I would have been definitely accepting that. But again, a head impulses, I still do not accept. Bilateral head impulse positivity, extremely rare. Yes, there have been reports of vermian lesions too, only in acute, because we don't get it in chronic that the head impulse is becoming positive, remaining positive. Yeah. Yeah.
Move ahead, sir.
Yeah, you go ahead. You go ahead.
So this is already discussed, so I'll not go into the slides of
Yeah.
realization.
Sure.
Investigation wise, blood investigations were normal, sir. Specifically, vitamin E levels were normal, and cardiac evaluation and hearing assessment was normal. NCS showed a demyelinating picture in the lower limbs with suggestive of uniform demyelination. There was no conduction block. MRI I'll be showing, sir. Basically, in 2018, we did 2 MRIs. Earlier, she had presented to us in 2018 when there was cervical cord atrophy. And her MRI was showing classical signs. Basically, there was these and I'll use a highlighter. So as you can see here in the pons, there are T2 hypointense stripes, sir, in the pons. Also, we can see the cerebellar atrophy. In the below images, basically there is atrophy of the superior vermian region. This was done in 2018. Subsequently, in 2025, when she presented to us again, we did an MRI where there was increasing cerebellar atrophy. As you can see here, there's significant increasing atrophy of the superior vermian region of the cerebellum. And the T2 hypointense in the pons was also seen this time also.
I think we have a very diagnostic MRA, isn't it?
Yes, sir.
This is an issue quite significantly characteristic.
Yes, sir.
Anybody else wants to, I mean, I know people who don't know the diagnosis yet who wants to venture, I think kind of gives away what we are dealing with. Anybody from the audience who wants to venture, I'm just checking. I don't think anybody coming in. All right. Okay. Yeah, please go ahead, Dr. Sanjana.
So genetic test we sent, which came positive for SAX gene mutation, which is suggestive autosomal recessive ataxia of Challiver-Segwani type. So treatment is basically supportive. So then it is end of my presentation. I would like, should I go ahead with a brief presentation how to approach, sir, of ataxia?
I think Dr. Jyotsna, do we have time or do we just move on to the next case given that you're now almost 1.5 hours in?
Yeah. I think Dr. Sanjana, the discussion has been extensively good, and I was just that's why going on, and the participant number is also hanging on, so that is okay. But if you could rush through it within a minute or two and focus only on
yes, no. Important ones. I'll play the last slide, ma'am. This is more important. So basically, any patient who comes with a chronic cerebellar ataxia with an onset of childhood onset, after ruling out the secondary causes, we have to follow this algorithm. Basically, you have to see whether there's a peripheral nerve involvement or there is no peripheral nerve involvement. When there is peripheral nerve involvement, it narrows down to these conditions like Friedreich ataxia, which is the most common autosomal recessive ataxia. We have close mimic, which is ataxia with vitamin E deficiency, ataxia telangiectasia, ataxia with oculomotor apraxia, and others like CTX, cerebrotendinous xanthomatosis, canvas, and polygyataxia, which is a mitochondrial disease. So then we see the MRI, that there are classical findings in the MRI which will point to the diagnosis. As in our case, there was T2 hypointensity in the pons, which is characteristic of URSACs. There is another important, that is when there is dentate hyperintensity in the MRI, it points towards a cerebrotendinous xanthomatosis. So as we know, if there is no cerebral atrophy, it goes in terms of Friedreich's ataxia. So one more thing we have to see here is that Friedreich's ataxia, there's a close mimic is the ataxia with vitamin E deficiency. How we differentiate is with the clinical symptom. It is said that vitamin E deficiency ataxia will have more of dystonic head tremor, and they will have more of retinitis pigmentosa. Whereas in Friedreich's ataxia patient will have more of other extra neurological manifestations like cardiomyopathy and pes cavus and other things. So then coming to, so suppose we have a cerebral atrophy, a patient with peripheral neuropathy and cerebral atrophy, we have ataxic telangiectasia and ataxia with oculomotor apraxia. Again, we go for alpha fetoprotein levels. If it is high, it narrows down to two diagnoses, ataxia telangiectasia and ataxia with oculomotor apraxia. If the alpha fetoprotein is normal, then it points to the other ataxia oculomotor apraxia types. Then coming to the other very classic symptoms of canvas, as Madam told, if they'll have a classic symptoms of vestibular areflexia and cough. And polygyataxia is a mitochondrial disorder, so they'll have other systemic features like epilepsy, external ophthalmoplegia, or myopathy. Then coming to the other part of the table, we have with no peripheral nervous system involvement. So we have so here MRI, so cerebral atrophy, if it is present, then it can be with, if it is a pure cerebral disorder, it is signed E1 ataxias. If there is motor neuron involvement, ANO10, and spasticity, SPG7. Without cerebral involvement, we have Niemann-Pick disease. So the adult form, which is a Niemann-Pick disease type C, where they'll have vertical gaze palsies, dementia, and other extrapyramidal symptoms. One more thing, lastly, I would like to highlight the red flag signs of treatable recessive ataxia. That is, ataxia with vitamin D deficiency has to be differentiated from Friedreich's ataxia because it's a treatable ataxia, and they'll have a classical dystonic head tremor. Cerebrotendinous xanthomatosis, with history-wise, they can have childhood jaundice, neonatal jaundice and diarrhea, and they can have classical xanthomas. And as I told, MRI T2 dentate hyperintensity. Niemann-Pick disease, also it is treatable with the miglustat, so you can have vertical gaze palsies and sphenomegaly. Very important to point out is that Wilson disease can have an isolated cerebral ataxia, but the extrapyramidal symptoms will happen with these cerebral ataxia also. So these are treatable, has to be kept in mind. So this, should I tell ma'am just briefly about RSACs, just one line. It is a triad of cerebral ataxia, lower limb spasticity, and axonal demyelinating neuropathy. The MRI features, what I got is 90% is present in the MRI, Pontine stripes, and they have superior cerebellar vermin atrophy. And so treatment is usually supportive, and they can have atypical manifestations. You are not audible.
Yeah, Dr. Josna, we can't hear you.
Can you hear me now?
Yeah.
Yes.
All right. So thank you, Dr. Sanjana, for the excellent presentation. I think Dr. Srinivas moderated it really well. Guru Prasad sir added his expert comments, and also Dr. Elavarisi. Thank you so much. And as a pediatric neurologist, two things I would take home is, as Dr. Sanjana rightly said, vitamin E and a mitochondrial cocktail when you're not sure while the genetic workup is being done. I think those two things, if we can supplement and not miss something treatable, that is a very important take home. We move on to the next clinical case. I invite Dr. Agam Jain. He is the assistant professor of the Department of Neurology at JIPMER, New Delhi. Dr. Agam, I welcome you. We thank you for giving us your time on today's YNF activity. Please introduce the speaker, and the stage is yours.
Thank you, ma'am. At the outset, I would like to thank Dr. Josna and Dr. Saraswati for giving us this opportunity. Orofacial dyskinesias are always troubling. Most of the time, they are thought to be tardive. Here, we describe a sign which is so pathognomic that it suggests the etiology. I invite Dr. Vipin Peet. She's a first-year senior resident. in the Department of Neurology. Over to you, Dr. Vipan.
Thank you, sir. And a very good afternoon, everyone. Today I'm presenting a case of an unpalatable candide. Our patient is a 78 years old gentleman hailing from Saharanpur, UP. He's a graduate, retired railway station master, with a known case of hypertension, COPD, CAD on medical management. He presented with chief complaint of abnormal movements of jaw and tongue for last 6 years. These movements were insidious onset, spontaneous, intermittent, non-rhythmic, repetitive, jaw opening, tongue protrusion and deviation to right, and side-to-side movements of tongue producing a clicking sound. They increased after speaking or eating, were partially suppressible, relieved by rest and tongue touching inner aspect of lower lip. These interfered with chewing, swallowing, and speech. They disappeared during sleep and there was no associated premonitory urge. Patient gave no history of tongue or cheek bite or abnormal posturing of upper, lower limbs or trunk. There was no history of walking difficulty or weakness of any limbs or sensory complaints. There was no history of intake of dopamine blockers, prokinetics, antipsychotics, or any medications for vertigo. No history of dental procedures or family history of abnormal movements, intellectual disability, or walking difficulty. A patient is a reformed smoker and alcoholic. He denies any high-risk sexual behavior and had adequate sleep. In his treatment history, he was on tablet tetrabenazine, trihexyphenidyl, clonazepam, aspirin, atorvastatin, bisoprolol, silodosin, and doxycycline. On his
Dr. Vipan, at the end of the history, what are your what do you make out of it, and what are your possible differences?
In the given scenario, typical movements involving his lower part of face, tongue, jaw, we are keeping a possibility, first possibility of oromandibular dystonias, and a second possibility of a common entity of tardive dyskinesias.
Okay. Since videos are important, we'll, in interest of time, we'll move ahead. Okay, go ahead with the examination.
Cheers. On systemic examination, apart from his blood pressure of 140/90 and prolonged expiration on chest examination, rest of examination was normal. There were no significant skin changes. I'm playing the video.
It's not audible.
Is it audible, sir?
No.
Audible?
No, not yet. Okay, go ahead, please.
Just a minute.
You have to share the audio with Zoom.
Hello.
Hello. I think you
Hello,
have to share
can
the
you hear
audio
me?
with Zoom. Yeah.
You want to share the audio?
Yeah.
Yeah, stop share the screen. This screen. When you share your screen, there is the option of share sound. You have to click that also. When you share your screen,
Okay.
there is a toggle of sound share.
Yes, got it.
What are you seeing?
Now this is a video. This is a video showing spontaneous, intermittent, non-rhythmic, repetitive movements involving lower jaw, tongue, and other facial muscles, producing a typical clicking sound as if patient is sucking a candle.
Is it stereotypic?
Yes, these are stereotypical movements. Partially suppressible.
What happens when the patient is speaking?
Yes, ma'am,
Yeah.
I'm coming to that.
Yeah.
This is, while eating.
ठीक, बस एक बाइट काफ़ी है। हाँ, इधर देखते रहिए, सामने देखते रहिए। सामने देखते रहिए। तो
सांस फूलना जी घबराना, उसकी आवाज़ में तो फर्क आ गया और ये मेरी चलती रहती है, रात ज़्यादा बनती है जो मुझे खाने में प्रॉब्लम पैदा कर रही है।
Persist during speaking and eating.
Does he have an associated vector speaking this spasmodic dysphonia?
Yes, ma'am, he does have it. He also complains of saying that he has a change in his voice, and it was present on our examination also.
When
Also
he's
notable,
speaking, it is significantly reduced, no? When he's eating and speaking, the movements are hardly there.
persistent though. Yeah. Thrown out was that he has to take it in his hand and reinsert.
तो मेरा सांस फूलना जी घबराना, उसकी आवाज़ में तो फर्क आ गया और ये मेरी चलती रहती है, रात ज़्यादा बनती है जो मुझे खाने में प्रॉब्लम पैदा कर रही है।
Notable
Other thing I wanted to ask Dr. Vipanpreet, does he have teeth?
Yes, ma'am, he doesn't.
Okay.
Why did ma'am ask for teeth? That's a very good
Because
question.
the possibility of edentulous dyskinesia is here. Now, apart from the examination, as shown in the video, patient had mild left more than right-sided aponeurotic ptosis and mild left more than right partial and intentional tremors. Now, to summarize our case, a patient is a 78 years old male who is a known case of hypertension, COPD, CAD, presented with stereotypic oromandibular dyskinesias, not abating during speaking or eating, without any history of intake of dopaminergic blockers, without cognitive functions, cranial nerve, or pyramidal or bladder bowel involvement. And we localized a lesion to basal ganglia and its connections.
At the end of history examination, what are your differentials?
Firstly, sir, given the typical dyskinesias and the movement of candy sucking, our first possibility is neurosyphilis. However, patient gave no history of high-risk sexual behavior. A second possibility is tardive dyskinesias, which also have stereotypical repetitive movements, predominantly affecting the oromandibular area. But he gave no history of use of dopaminergic blockers, and these movements persisted during eating and speaking, and also they caused significant functional limitation in his speech and feeding. Third possibilities of oromandibular dystonias, idiopathic or tardive. However, there was no history of, there were no abnormal sustained postures or muscle contractions. Lower down possibilities include tics, idiopathic oral dyskinesias, polycythemia vera, genetic chorioacanthocytosis, and NMDAR encephalitis. Now, on investigations, his routine investigations were normal. The serum RPR was reactive. and TPHA was weakly positive. MRI brain was suggestive of Fazeca grade 1 changes. CSF was unremarkable and CSF VDRL was negative. A final diagnosis is oromandibular dyskinesias secondary to possibility of neurosyphilis, possibly resolved or sequelae.
Can you tell a little bit more about the candy sign? And
Yes, sir. The candy sign, it has been described long back in patients of neurosyphilis, and it is considered as pathognomic of neurosyphilis. And these involve typically the lower facial, mandibular, and tongue muscles. And the main thing is a clicking, candy sucking sound. The US CDC 2018 criteria for neurosyphilis includes for definitive, we need serum TPPA reactive, serum RPR reactive, and CSF VDRL positive. The probable criteria include serum RPR reactive, serum TPPA positive, and CSF total count of more than 5 cells or proteins more than 50. Now, given the possibility of neurosyphilis, injection aqueous penicillin G was not available. We managed a patient with injection ceftriaxone 1 gram BD for 14 days. Tablet tetrabenazine was continued, and patient was given injection botulinum. Under ultrasound guidance, in bilateral lateral pterygoids, digastric platysma, and genoglossus, and right zygomaticus major and minor and mentalis for the facial twitching seen on right side. Unfortunately, a patient developed dysphagia and had to undergo Ryle's tube insertion and Ryle's tube feeding for around 1 week. Now, coming to the injection Botox techniques for jaw opening movements, we give injections in lateral pterygoids and submentalis complex. For lateral pterygoids, injection Botox is given at a point around 3 centimeter anterior to tragus and 1 centimeter below the zygomatic arc. For the submentalis complex, we give injections around 1 centimeter below the mandibular tip, slightly lateral from the midline. For the jaw closing movements, we give injections in masseter, temporalis, and medial pterygoid. For the masseter, we ask patient to clench his teeth, and injection is given in a safe zone between the 4 imaginary lines. First line is from the tragus to the labial commissure. The second line is the inferior jaw and margin, and the 2 lines, third and fourth, are from the anterior and the posterior margins of masseter. For temporalis, we give injection in high in the temporal fossa in the thick muscle fibers around 5 centimeter above the insertion of temporalis. And for medial pterygoid, we can use the intraoral or external technique. We give injection around 0.5 to 1 centimeter anterior to angle of jaw from the inner aspect of the mandible. For lingual dystonias, family as a patient had protrusion type dystonias, we give injection in the bilateral genioglossus in the posterior fibers, for the retraction type in the anterior fibers of genioglossus, and for the lateral protrusion type in the ipsilateral superior and inferior longitudinal, and for curling type bilateral superior longitudinal muscle. For the zygomaticus major and minor, we draw 3 imaginary lines from the lateral canthus of the eye. First is from the lateral canthus of eye to the labial commissure. The second is from the base of the nose, a horizontal line. And the third is a vertical line from lateral canthus of eye meeting the horizontal line. At point B, give injection in the zygomaticus major, and point C in the zygomaticus minor. Now, as already described candy sign, it was firstly coined by Camilo Negro in 1913. It is considered as pathognomic of neurosyphilis. These are orofacial dyskinesias involving lower facial muscles, jaw, and tongue. And these reproduce a movement performed in normal life, that is candy sucking. The pathophysiology involves ischemic injury to basal ganglia as a consequence of syphilitic vascular disease. In an 11-year retrospective study done in China by Yang et al. In the neurosyphilis patients, they found candy sign to be in 10% of their patients and was commonly seen in patients of general paresis, followed by multiple times. Other movement disorders seen in neurosyphilis include tremor, chorea, Parkinsonism, In the post-antibiotic era, the typical presentation of neurosyphilis is the atypical forms, and significant heterogeneity has been found in literature in terms of how syphilis was diagnosed and terminologies used, like for tongue movements, candy sign, trombone tongue, trombone tremor of the tongue, stereotypical dyskinesias, coarse tongue tremors, and others have been used. Now, although neurosyphilis is a treatable condition, the reversibility is dependent on the severity and duration of disease. Late syndromes like progressive dementia, psychiatric personality changes, movement disorders, and dysarthria, these respond little to penicillin. Now, coming to tardive dyskinesias, these are stereotypical movements predominantly, again, involving orobuccolingual areas, and we need exposure to at least one dopamine blockers for at least 1 month within 6 months of the onset of symptoms and lasting for at least 1 month after discontinuation of dopamine blockers. These typically decrease on talking and chewing and do not cause much functional limitations. They worsen with anticholinergics and are also associated with akathasias, marching in place, and truncal rocking. Oromandibular dystonias, as already mentioned, can be idiopathic, again drug-induced, genetic, and they are worsened by actions such as speech and eating, and there is presence of overflow or geste antagonistic. Now, for management of orofacial dyskinesias, we need to treat underlying cause. For tardive dyskinesias, we need to remove offending drug or switch to relatively safer antipsychotics, clozapine or quetiapine. For symptomatic treatment, we can give valbenazine, deutetrabenazine. These are the only FDA-approved drugs for tardive dyskinesias. Botulinum toxin or deep brain stimulation in refractory cases. Proper dental and oral evaluation to assess for edentulous or poor fitting dentures or rehabilitation therapy. Now, all the high quality evidence is lacking. Clinical experience suggests efficacy in orofacial dyskinesias. EMG or ultrasound guidance is essential. Now, adverse effects of Botox injection include dysphagia, which is the most common effect seen in the systematic review involving 387 patients treated with Botox. Others include dysarthria, temporary regional weakness, asymmetry or loss of smile, muscle atrophy, lip numbness, paresthesia, mouth dryness, transient edema, itching, headache, hematoma, bruising pain, and tenderness at injection site. Now, for dysphagia after injection Botox is commonly seen after injections in sternocleidomastoid, scalene, and genioglossus. It occurs due to spread of Botox into adjacent tissue. Risk is significantly increased in patients with multiple comorbidities and previous history of dysphagia. Ultrasound guidance is unable to prevent it. Therefore, minimum required doses should be given with adequate technique, and other management strategies should be applied in patients with pre-existing dysphagia. Thank you for this opportunity.
Thank you, Dr. Vikrampreet, for the nice presentation. Dr. Agam, do you have any further remarks?
I just want everyone to understand that this is a very pathognomic site. The more you see it, just have a picture in your mind, and the next time you encounter a patient with orofacial dyskinesia, if you encounter this, please do send VDR or TPHA, and it may help change diagnosis and management of the patient.
Absolutely.
Dr.
Yes.
Agam, thank you for the presentation and all. But I think, see, basically, in neurosyphilis, basically we look at meningovascular syphilis, tertiary syphilis, because the MR is not supportive of that, because you need to have some ischemic changes or like stroke-like events. See, when someone you see elderly with oromandibular dyskinesia, unless otherwise proven, is tardive dyskinesia. Candy sign probably was described many decades before, when all this tardive dystonia is all nothing. So I think one clinical sign equal to that, I think those are the days, early days. Now I think you should look at more common thing first. Tardive dystonia is the first thing. I mean, detailed history, sometimes, you may not get history, get all the drugs what he has taken for 10 years, 15 years. Look at that first common and then thing. So one thing is that. Another thing is that's what if you have stroke-like events, because neurosyphilis, tertiary syphilis, because of the meningovascular events, stroke-like events, you develop that type of oromandibular thing. So you need to have that correlate, anatomical correlate also for describing that. But how's the response to antibiotics and all? Is the patient better?
No, sir. Like with the antibiotics, there was no, but at the same time, he received Botox, so the movements did subside. And totally agree.
Another teaching point also is that when you look at elderly with starting the Botox injection, start very low. As I mean, as your presenter told, the starting dose for genoglass should be very very low. Even though the range is anywhere between 10 to 40, I
Yes,
would probably go like 2.5 units on either side. I would not go beyond that initially, the initial dose, because they're all the muscles are contiguous.
yes,
They are all spread into the pharyngeal muscles and all. It's not there's no capsule where it will prevent the spread. So you have to be very careful when you're using the doses like that. So 10 units, a little higher to start with for Genio.
okay, sir.
And then next time you can probably 3 months, 6 months down the line, you can go a little higher, especially elderly. So that can prevent dysphagia and all. Yeah. Otherwise,
Okay, sir.
very nice presentation and very nice case.
Thank you,
Thank
sir.
you, sir. Dr. Ilavarisi had a comment. She has raised her hand.
Yeah, I agree with Guru sir to a large extent. We also had recently seen a patient with candy sign, and I had admitted it from the OPD. I thought it would turn out to be neurosyphilis, but all the workup was negative, including both CSF and serum. And the other thing that we need to see is that you had mentioned that the patient had white matter changes in the form of Fazekas changes. So in our patient also we had ultimately we made a diagnosis of some vascular Parkinsonism or vascular small vessel ischemic disease. So it is a good idea to look prospectively and see if we find from the stroke clinic or uh, the cognitive clinics, if we are able to find candy sign presence in these sort of patients who have small vessel ischemia. That is one. And second thing I wanted to say was you said that the pupillary light reaction was normal, right?
Sorry, ma'am.
Pupillary light reaction,
Yeah.
the presenter told
There
that
was,
it was normal.
there was no Argyle Robertson pupil.
Sorry?
Yes, ma'am. There was no Argyle Robertson pupils.
Yeah, so that is one. Of course, it is not very sensitive. It may be present in only 30% of patients with neurosyphilis. But the other thing that was quite odd is the TPHA was also weakly positive, you said, right?
Yes, ma'am.
Can you show what it was like in the serum and CSF? What was positive, what was negative?
Dr. Vipin, can you
Yes.
go back, right? Dr. Vipin?
Yes, sir. I'm doing.
These are the serology reports, ma'am.
What about the CSF TPHA?
We could not get a CSF TPHA, ma'am. It was not available at our institute. The patient was not affording to get it done from outside.
So we should be careful in interpreting these findings because TPHA, once it becomes positive, it will remain positive for the rest of the life.
Yes,
And
ma'am.
VDRL and RPR, as you rightly said, in partially treated patients or in patients who have exposure to antibiotics, it may turn out to be negative. Now, in this patient, we don't know how much antibiotic patient has received, any over-the-counter medications. We don't know, but if TPHA is negative in CSF, it is very unlikely we are dealing with a case of neurosyphilis. I mean, you
Yes.
can take opinion from an infectious disease team. I am not a ID person, but that is the classical interpretation of the serology and CSF findings in syphilis.
Just because the serum RPR was positive, we decided to treat because okay, unnecessary risk. Otherwise, I do agree, ma'am.
Any further questions? Shall we move on to the next case? Dr. Agam?
Yes, sir.
Yes, right. Thank you, Dr. Agam and Dr. Vipalpreet. I now invite the last case for this session, Dr. Hemant Luniwal, Assistant Professor, Department of Neurology at AIIMS Jodhpur, will be moderating this session. Welcome, Dr. Hemant, and thank you for giving us your time. Please introduce the speaker and take over the session.
Good morning, Saraswati Madam and Jyotsna Madam, giving this opportunity to present a case here in good platform, YNF Neurology. And I would like to thank you, my HOD, Dr. Samita Panda Madam, for giving me this opportunity to present here. And Dr. Anjana, she is our final year resident. She is presenting a case of atypical myasthenic patient, ma'am. And now, Anjana, you can start. I'll
Thank you,
share
sir.
PPTs here. This is visible to all of you.
Yes.
I'll make it full screen. Start, Anjana.
Thank you, sir, and thank you everyone for this opportunity. So I'll go ahead with my case. My patient is a young male. He's a 25 years old right-handed male, and
It's not coming.
My patient is a 25-year-old right-handed male born of non-consanguineous marriage with a normal development and birth history. And he presented to us with a total duration of illness of 3 days. First complaint was he noticed imbalance while walking. He noticed it first when he was coming home after work, and when he was climbing the stairs in his home, he noticed that he could not place his feet exactly at the point where he wanted to keep, and he felt a swaying while walking and associated with a feeling of dizziness while walking, but there was no history of falls. And this was progressively worsening such that after 2 days he needed support to walk. He was not able to walk unsupported. And on the same day evening, when he started developing the complaints of imbalance, he also noticed blurring of vision and double vision. And this was present for both near vision as well as far vision, and was not associated with any headache or redness of eyes or tearing from the eyes, and no nausea, vomiting. And this was also progressively worsening over the last 3 days. And the next day, after the onset of complaints of imbalance, his relatives noticed a change in his speech. They noticed that his voice had become heavy, and that they felt that he was using extra effort or extra force while he was speaking. And this entire illness was preceded by a history of upper respiratory infection 3 days prior to the onset of these complaints. And that was managed with over-the-counter medications. He did not get evaluated, or he did not get admitted for the same.
Anjana, did he have any ptosis that time on presentation?
No history of ptosis at this time of presentation, only blurring and double vision.
Okay.
And his past history was significant. He is a diagnosed case of ocular myasthenia gravis since 2023. So at that time, he presented to an outside hospital with subacute onset, progressively worsening diplopia and blurring of vision with fatigability and diurnal variation. He was admitted and evaluated. His anti-acetylcholine receptor antibody was positive, and during evaluation, he was also detected to have a thymoma. Then he was started on steroids, and he was also started on azathioprine. And this is his treatment history since 2023. Initially, he was started on pyridostigmine, oral steroids, and tab azathioprine. Then over the course, when he symptomatically improved, later pyridostigmine was stopped. Steroids were also gradually tapered and stopped. And now he is still on azathioprine immunosuppression. And since the last 2 years, he did not have any relapse, and there was no drug default in between. And family history, there was significant family history of diabetes, hypertension, and CAD in the family. And his grandmother has history of CA breast. But other than that, there was no history of any other malignancy or any similar illness in the family. So on examination, his vitals were stable, and there was no.
Anjana, before examination, what is your possibility based on history?
So history-wise, he is a young male who's a known case of ocular myasthenia gravis on immunosuppression, who presented with acute onset, rapidly progressive cerebellar, pan-cerebellar syndrome, I would consider, with gait ataxia plus speech abnormality and vision, blurring of vision also, without any other pyramidal or extrapyramidal or other cranial nerve features, with a preceding history of upper respiratory infection in the last 3 days.
Did you keep possibility of myasthenia crisis also?
Yes, it is also possible because he's a known case of myasthenia gravis, although he did not have any ptosis and he was not reporting any diurnal variation of fatigability, which was there in his first presentation, but still that has to be ruled out in any case of myasthenia when they present.
Okay. Now examination.
And on examination, patient's vitals were stable. He did not have pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. And he was not in respiratory distress. Respiratory rate was normal. Other system examination was normal. And his fatigability test came out to be negative. He did not have any ptosis or nasal intonation. Single breath count was 15 and arm abduction time was more than 2 minutes. And in central nervous system examination, he was conscious, oriented, and cooperative. And GCS was full. Speech was scanning speech. I'll be showing a video. And his pupils were bilaterally reactive to light. No RIPD, and fundus did not show any papilledema. Visual acuity was 6/18 on the right and 6/9 on the left. His extraocular movements were full, but he was telling diplopia on down gaze. And there was gaze evoked and as well as torsional nystagmus, left side more than the right side. There was no facial asymmetry, and uvula was central and gag reflex was present. And motor examination, he did not have any wasting. There was hypertonia in both lower limbs. Upper limb tone was normal and truncal tone was also normal. Power was 5/5 in all the limbs. Reflexes were 2+. Plantar was flexor. Superficial reflexes were present. Sensory examination was intact and there were no signs of meningeal irritation. And examination of cerebellar signs, as mentioned earlier, he had gaze evoked nystagmus and all his cerebellar signs were positive. Finger nose, finger nose, and heel shin test was all impaired on the left side more than the right side. And his diadechokinesia was also present on the left side. His gait was also impaired. He had an ataxic gait, broad-based gait. So this is a sample of his speech. So here we can say that I would describe the speech as scanning. There is increased space between the syllables and he's pronouncing syllable by syllable. He does not have the classical staccato speech, but sometimes there is undue stress on some syllables, but still not classical staccato. And describing the gait, he's unable to stand unsupported. He's having a wide base. And while walking also, he's having a wide base and he's swaying to all directions, forward, backward, and to the sides. And his ground clearance is almost 0 because he was having severe swaying once he lifts the feet off the ground and tendency to fall. So to summarize, we have a young 25-year-old male who's a known case of ocular myasthenia gravis on immunosuppression with a thymoma, who with preceding URI followed by acute onset rapidly progressive pan-cerebellar syndrome, because there is impairment, gait ataxia plus appendicular ataxia plus speech impairment and nystagmus also. So it is a pan-cerebellar syndrome, I would consider. And to consider the etiologies, since it was an acute onset rapidly progressive syndrome and with a previous history of upper respiratory infection and for a patient being on immunosuppression, first possibility that we entertained was a post-infectious or a para-infectious cerebellitis, most likely due to a viral cause. And second, since thymoma is known to produce multiple autoimmune phenomena as well as paraneoplastic syndromes, so we encourage that as a second possibility. So we admitted him for evaluation. Basic investigations, the liver functions, renal functions, electrolytes and counts were normal. And his inflammatory markers were also normal. Viral markers were also negative. And metabolic profile, including thyroid function test, vitamin D, vitamin B12, HbA1c, all came out to be normal. And this was his CSF studies. CSF was showing 4 lymphocytes and 20 RBCs, and protein was elevated, and sugars were within normal limits, and rest infective workup in the CSF ADA culture, acid fast staining and India came to be negative. His CSF viral panel was also sent, which was awaited at that time. And we got an MRI done for him. This is MRI T2 flare and post-contrast sequence of the patient, which was done at the time of admission. And here's a video of the MRI. And this, we can see that there are bilateral T2 flare hyperintensities, which are also contrast enhancing, involving both the cerebellar hemispheres and the vermis, left side more than the right side. So which correlates with the patient's clinical features. This is a cerebellar hyperintensity, which is visible here.
Any cortical and subcortical lesion in first MRI?
No other. Rest of the MRI is normal. There was no meningeal enhancement, no other cranial nerve enhancement, and no other cortical involvement, only cerebellitis. So, since the CSF or MRI picture could also be seen in a viral cerebellitis, like we thought, a post-infectious phenomena, we treated with injection acyclovir, ceftriaxone, IV fluids, and other supportive measures. And thinking it to be an infectious etiology, we had withhold his immunosuppression as well. But the patient did not demonstrate any improvement with this. And we got his CT and PET also done. By that time, the CSF viral panel came, which was negative, and we got a CECT abdomen, which is showing a homogeneous enhancing mass in the anterior part of the mediastinum, which was correlating with this thymoma, which he already had. And
here,
this is the thymoma in the anterior mediastinum. And his whole body PET was done. That was showing a metabolically active lesion in the anterior mediastinum, likely thymoma, and a hypermetabolism in the cerebellum and the vermis, likely a paraneoplastic syndrome. And there was no other evidence of malignancy or any other metabolically active disease elsewhere in the body. So with this and his paraneoplastic and autoimmune panel also came back by this time. His AMPA receptor was strongly positive, anti-titin was also positive, and anti-GAT65 antibodies were also positive. So since he didn't improve with the antivirals and antibiotics, and now the PET is suggestive of an autoimmune paraneoplastic picture, and this paraneoplastic panel also came positive. So the second possibility was an autoimmune paraneoplastic syndrome. So we took him up for thymectomy. His thymectomy was done on 4th December 2025, and after that we gave him a cycle of IVIG also. And this is the video of the patient after surgery. So here we can see that there is a significant improvement in the gait of the patient compared to his time of admission. He's able to walk just with minimal support, and still some ataxia is there, but there is improvement after IVIG. And then the biopsy report came back. It was a thymoma type AB, and patient received 2 more cycles of IVIG. And this is the repeat MRI which we had done 3 months after the onset of illness approximately. So here we can see in this there is a significant resolution of the flare hyperintensities which were seen in the cerebellum, but he is having new cortical lesions, cortical subcortical lesions which have come up now in the MRI. And in his current status, currently he's post thymectomy, post 3 cycles of IVIG, on oral steroids, and he's on azathioprine. And his ataxia has improved. Speech has also improved. There is no nystagmus now. He's almost touched the baseline. He's able to carry out his daily activities, and he's able to walk unsupported. And no new symptoms have come up after the first admission. And this is the overall timeline of the patient. He developed the first acute onset progressive ataxia on 20th November, or progressed rapidly over 3 days. Then initially we admitted and we gave antivirals, antibiotics, and IV steroids. He did not improve. He started improving after the thymectomy and he showed significant improvement after IVIG, and he has completed now 3 cycles of IVIG and almost returned to his baseline status. And we have reviewed some literature of similar case reports, and I'll be showing some of them. This first was a female. She was a 42-year-old female who had bulbar symptoms, gait disturbances, and behavioral symptoms. And she was found to have AMPA receptor antibodies in the CSF, and she was also found to have a thymoma. And she was also given immunomodulation, and she showed significant improvement. And this is another case report where a patient having thymoma presented with features of myasthenia, myositis, and myocarditis. And this patient was found to have anti-GAD65 antibody. So this was also found in our patient. This antibody was also positive. And this is another case of thymic carcinoma, thymic neuroendocrine tumor, where the patient had anti-GAD antibodies and they presented with cerebellar ataxia. And this is characterization of AMPA encephalitis between children and adults. In this case series, they have found that initial presentation with a behavioral manifestation or a cerebellar ataxia is more common in children, whereas adults usually tend to present with encephalitis, seizures, or psychosis. But in our patient, the first manifestation was that of cerebellar manifestation only. And this also found most common malignancy as small cell lung carcinoma, second to be thymoma associated with AMPA encephalitis. And this is another case series of patients who are having AMPA receptor encephalitis, autoimmune encephalitis associated with thymoma. In that, the most common antibody was GABA, and second most common antibody was found to be AMPA encephalitis. And in this previous case, we can see that this AMPA encephalitis having these typical MRI cortical and subcortical lesions, like the one that was seen in the follow-up MRI of our patient, although he did not have any features of encephalopathy or seizures. This is also outcome reports in patients having AMPA encephalitis. Here, they had a 44-year-old man. He had a thymoma and he developed myasthenia gravis, and the patient was taken up for thymectomy. And after thymectomy, the patient developed features of AMPA encephalitis. So he was treated initially with IVIG, but he did not improve. Then he was given rituximab, after which the patient had a resolution of the encephalopathy. So even after thymectomy, also patient can have this paraneoplastic manifestations. So my take-home message is that in the context of a thymoma, treating the tumor alone or treating the initial presentation of a myasthenia gravis alone will not be sufficient. We have to treat the entire autoimmune spectrum for better long-term clinical outcomes. Thank you.
Thank you, Anjana.
This presentation, Dr. Anjana. Few things what I want to add is that very good points, well taken. Few things what is important is that basically that the autoimmune encephalitis was triggered by URTI. For me, it looked like initially focal demyelination, like a focal ADM like presentation, and then the MR again the latest MR showed multiple lesions, so it was very clear. And the anti-GAD antibodies were mildly positive. It is more AMPA, which is significant, I think. I think 2 plus or 3 plus antibodies. I think the GAD of 65 was mildly positive.
It
So
is
it
only
is
weakly
whatever it is,
positive.
it's more it is weakly positive. It's more ANPA antibodies which are strongly positive. So so what do you think, the thymectomy helped or IVIG helped?
Sir, both are required. In a case of thymoma associated paraneoplastic, first, definitely the tumor has to be removed, and immunomodulation also has to be given, because since AMPA also came positive, usually AMPA is a very aggressive autoimmune encephalitis. Patients tend to go into severe encephalopathy, so we should treat them with immunomodulation also. So, like in
So
that
if I
case
would have been
report
in
that
your
I had,
position, I would probably treat with methylprednisolone if patient is not in crisis, like situation myasthenia, because you straight away gave antiviral. In fact, acyclovir can worsen the ataxia. One of the drugs which can cause cerebral ataxia is acyclovir and valacyclovir. I would have been in a position, I would have started either steroids or IVIG straight away to treat and whatever happens is if there is a encephalitis, that probably also will worsen the myasthenia. So I'll probably do a immunomodulation. The thymectomy is to maintain the remission. So thymectomy is not to push the patient into remission. You need to take help of immunomodulation, either in the form of steroids. Steroids sometimes can have paradoxical worsening. So you have to be careful. So either you do plasmapheresis or IVIG to start with a small dose of lower dose steroids, and then prepare them for thymectomy. Thymectomy is the solution for thing. Here, what I think made the difference to the patient is the IVIG, not the thymectomy. Thymectomy will have long-term remission effects. Young patient that definitely requires thymectomy. And then for autoimmune encephalitis, you probably have to maintain long-term immunomodulation. Thymectomy will not work. So the patient, that's the reason why you'll probably have more lesions coming up. So I think you have to maintain steroids and probably look at rituximab or some other form of long-term immunomodulation. So I think there are two different pathologies. I didn't find any, references about thymoma and thing. And one thing which is important is to keep in mind that you probably have to repeat PET scan probably a year or 2 years later, because AMPA is not usually associated with thymoma. You can have malignancy because the antibodies, autoimmune encephalitis, paraneoplastic syndromes can predate your malignancy. So you may have land up with small cell carcinoma or a GI malignancy coming up later. So you need to keep a close watch on this gentleman. I don't think you should leave it myasthenia, and I think this is entirely different, autoimmune and thing, so they're not related. Good, they have done well in terms of treatment, but I think that's still I think one thing is long-term immunomodulation and keep a close watch on his other malignancies, because I have at least 5-6 year patients who had GI malignancies presenting with myasthenia. So if you don't have a thymoma, you always should do a PET scan in the myasthenic patient. You may pick up some other malignancy.
Okay, sir.
So
Yes.
that you need to keep it in mind.
How often would you suggest, sir? How often would you suggest doing the
They
PET?
say 15% of myasthenics can have malignancies. More so GI malignancies. So I have, in my series, I have some 5-6 patients, mostly colonic malignancies. We had one stomach malignancy. So if you don't have, your SHRS antibodies are negative, then, Musk negative. Nowadays, newer antibodies are there, titin and all. If it is negative, then you definitely need to do paraneoplastic workup and PET scan,
Once in
because that will completely change.
how often, sir? How frequency of
No,
doing the
initially for diagnosis, but if, for example, there are other systemic effects, you have a good remission in myasthenia, but patient loses weight, or you have difficulty in maintaining remission maybe a year later or 2 years later, you need to repeat a PET scan.
Okay, sir.
Yeah.
Thank you, sir.
We also plan for the repeat MRI scan after 3 months to look the any progression of the cortical or subcortical lesion, and how it behave. Even in the patient receive all kind of treatment, initially with IV MPS, then they underwent thymectomy along with the IVIG. Still, he had shown some new lesion in the repeat scan. So that's why we are keeping closely watching his symptoms, and we are planning to repeat MRI in next 1 or 2 months, sir.
Yeah. Keep a close watch. I think there are dual pathologies. I think.
Yes, sir. Yes. Thank you so much.
Right. Thank you, everyone, for sharing your wonderful clinical cases with us. And also to Guru Prasad, sir, for having stayed through the entire session and given his expert inputs. I think invaluable dissection of cerebellum and movement disorders. We thoroughly enjoyed the session. Thank you, one and all, for being with us. Thank you, Guru Prasad, sir. Thank you, Dr.
Thank you all.
Thank you, Srinivas.
Thank you, Dr.
Dr. Hemant.
Josna. Thank you, Dr. Saraswati, and all the presenters. Thank you. Thank you for having me. Thank you.
Thank you, sir. We will declare the session closed. Asmitaji, please do the name.